Cool. Let me just quickly share my screen. Cool. Can everyone hear me?
Yeah, you're good to go.
Okay, cool. So good afternoon, everyone. Thanks for joining in. So today, myself, Troy, and my colleague Ingrid Dreyer, we will be presenting common ENT conditions that you might encounter in the primary healthcare setting. So next slide. So a quick overview. So what we're going to do for this is we're going to speak about ENT and try contextualize it in the primary healthcare setting and just sort of put it against the backdrop of what specialized services are available in the sub-Saharan setting, as well as a quick caveat on how now ENT conditions and COVID-19 relate. I'm going to quickly touch on just revising some key examination techniques when it comes to examining the ear, nose, and throat. And then the conditions we will cover in today's presentation, hopefully make them a bit more interesting, is we're going to be looking at that which is primarily covered in the EDL. And we decided to add 3 more conditions which weren't in the EDL, the APC, but we felt that you did experience in everyday practice, which was dizziness, foreign bodies, and impacted cerumen. So ENT conditions in primary healthcare. So the point of this slide, I hope by the end of the slide that you might get an appreciation of the context to which we find as sort of primary healthcare workers and our relationship to ENT diagnosing, picking up and managing these conditions. So the spectrum of conditions are seen by us, but are neglected in the undergraduate curriculum, which CDAT and colleagues in 2012, which is a South African article, was addressing that they were concerned about that moving forward. In terms of what Pierre in 2013 in the South African Medical Journal said that almost 20% of our visits to GPs involve ENT, and the pediatric visits can be as much as 50%. So that's already showing you that a lot of patients that come in are complaining of ear, nose, and throat problems. And in the same article in 2013, so albeit old data, I think it still captures the fact that there perhaps is not a lot of specialists going around in ear, nose, and throat that you can refer to. This article said that less than 35 full-time ENT specialists. So thus we can conclude that the majority of ENT problems really are managed by us, the primary healthcare doctors. Maufa and colleagues in 2017, they did an audit of sub-Saharan African ENT audiology and speech services via a questionnaire and survey. And between the periods of 2009 and 2015, figured that there hasn't been much progression in what the services that are provided. So again, I'm trying to paint the picture that we see a lot of it ourselves, and there's not a lot of specialists around there to be managing the bulk and the burden of the disease that we see in terms of ENT. And Pierre colleagues said that the delayed referral of complicated conditions really does result in poor outcomes. I think in the article they said that close to 50% of hearing loss is actually preventable hearing loss. So that's quite big. So I think at the end of the slide, I wanted you guys to just take away that we are responsible at trying to do the best job we can, being equipped to pick up the basic conditions and have a good appreciation of when we need to refer on to the limited services that are currently available to us. So quick COVID-19 caveat before we go on to the discussion. I just took the most recent PUI case finding definition of the NICD guidelines. I'm not going to read through it. This is just for your own interest to look at, but to stress that upper respiratory tract symptoms within or 14 days is technically a PUI and warrants testing. So in fact, a recent literature review in, when was it, article in 2020, said that although ENT manifestations of COVID-19 are not as common as fever and cough, the manifestations are sore throat, headache, pharyngeal edema, nasal congestion, sort of conditions plaguing the upper respiratory area. So I just wanted to put the slide in to be mindful that when you're seeing ENT conditions, that you must always just be considerate that it may be COVID, and that you must take the necessary standard universal precautions when you examine these patients so that you are obviously safe in the whole process. So a quick reference to the examination. This is just from Tally and O'Connor. I'm not going to read all of it. It's a bit text heavy. It's just really for your interest. And what I wanted to stress with regards to otoscopy in the slide is that remember that whole mnemonic of right, right, right. So you use your right hand, you hold the right otoscope when examining the right ear of the patient, and that you must grab the tragus of the ear gently, pulling it backwards and upwards to straighten the ear canal. And the rest of the examinations there, if you guys are interested. So I don't think that's really the focus, just a quick anatomical review of the ear. And in terms of the nose, we only really do anterior rhinoscopy. You know, we're not doing anything that's examining the back. So we only really can comment on the nasal concha that you can see. And so just an appreciation of the sinuses. And in terms of the throat, you can just adopt a sort of outward in approach when looking. And I just want to stress again about universal precautions, because obviously you're putting yourself at risk when you ask the patient to open their mouth. So let's talk about the ear. So the EDL, we started off, we're going to take an outside in approach and start off by discussing otitis externa. So described as inflammation of the external auditory canal, whether it be infectious or non-infectious. In some cases, this inflammatory process can extend to the outside of the ear. So you will see it even before you put in an otoscope. Etiologically speaking, it's commonly bacterial superinfection of the skin there. And you must also consider that it might not be that. It could be local factors causing irritation, such as trauma, eczema, perhaps systemic dermatological conditions like psoriasis, or perhaps a foreign body or cerumen that has been resting there a little too long. So what's your patient going to say to you? So they're probably going to walk into the consulting room complaining of a painful ear. Maybe they say it's pruritic. Maybe they say something's coming out of the ear. However, it's going to be exacerbated when you touch the ear, and you might find that the pain is disproportionate. I want to make a quick mention of that this condition, otitis externa, and one that I'm going to discuss in a few slides' time, namely chronic suppurative otitis media, can look fairly similar. So historically, might be the only place where you manage to tease the two apart, and I'll just emphasize this again when we get to that in the next slides. So here's some pictures just so you guys can get an idea of what you may be looking at. So as you can see in the far most right picture, that there it has extended to the outside of the ear canal, and these other more dramatic ones just showing you that it's predominantly inflammation of the external canal. And if you can make out the tympanic membrane, in less severe cases, generally shouldn't be affected. So what can you do for them? So what the EDL suggests is general measures, and these general measures for most of the conditions are fairly the same. You want them to keep the ear clean and dry, and you always want to encourage your patient to not be putting anything in the ear, instilling fluids or putting in any earbuds or something like that. And then pharmacologically, you can just manage their pain, and you can, if available at your clinic, give topical agents like acetic acid, and consider antibiotics if you think it's a localized swelling. Something that I didn't mention in the beginning that I just want to mention now is that we didn't put any doses of any of the antibiotics that you can just look up in any sort of reference textbook, maybe the SAMHSA, EM guidance, whatever you choose to use to look up drug doses. In terms of referral, if you think it's vesicular lesion, you perhaps think it's ear cellulitis, or you have dutifully tried to cure it and there is no response. So now we move on to otitis media of the acute nature. So this is an infection of the middle ear, and this is commonly what you do see. Understand it can be viral or bacterial. They most commonly complain of pain. They might say they can't hear, or they have since lost hearing, but often the pain and the hearing coincide. On examination, you will see an unhappy tympanic membrane, red, bulging. It's not reflecting the light off your otoscope normally. There may or may not be perforation. The EDL says the following, that mild redness of the eardrum and rubbing of the ear, not reliable signs in children. However, just doing some reading, we found an NCBI article fairly recently that was just saying that you should appreciate that it's a diagnostic dilemma in the pediatric population, and things like tugging of the ear, general unwell, not feeding well, may be telltale signs that this child has otitis media, but just to appreciate that it's not as clear cut in the pediatric population. So on the bottom right is what a normal TM should look like, and then all the others are variants of middle ear infections. You can see erythema in the top slide, the left and the sort of bottom middle one. You can see that there's some pus in the middle ear, and then the top right is quite a frank perforation of the tympanic membrane. So how do you manage it? Generally speaking, you're going to just, again, encourage a patient, don't instill something, try to keep the ear dry as possible. Consider that this may be a symptom or presentation of an underlying systemic condition like HIV. Pharmacologically, antibiotics, of which amoxicillin is the first line in the EDL that you should be using. You can consider clavulanic acid if this patient has received amoxicillin or hospital admission in the last month or so to increase your coverage. And please be mindful to the pain by prescribing them analgesia. So when would you refer this patient? So if you think anatomically, you're really just concerned that this middle ear infection is perhaps something more. So it's signs of meningeal involvement or perhaps extension into the mastoid. So either mastoiditis or suspected meningitis. And then they make mention of whether it's recurrent episodes that you can't manage. And then this last point, which I thought perhaps just spoke to the fact that it may be a more serious infection than you initially thought, that if there's no response within 72 hours of adequate treatment. Moving on to chronic suppurative otitis media, which is the one I said be mindful to differentiate from Otitis Externa. So this is described as a purulent discharge with eardrum perforation of more than 2 weeks. If it has been, the eardrum has been ruptured for more than 2 weeks, a secondary infection with multiple organisms must be considered. And in our setting, TB is always a consideration. This is something that starts typically in early childhood, and the child profile that you will be looking out for to think that might be at risk for this condition, which is shown to be one of the conditions that causes or is avoidable hearing loss, is the children with craniofacial abnormalities such as cleft palate or perhaps Down syndrome. I put some risk factors up there for your own interest if you peruse this presentation again, and that the pathophysiology of this condition is multifactorial. I'll show you in the slide coming up that it's really many players all working together to cause a disruption of the normal middle ear milieu. So symptoms, this one, they typically complain more of discharge from the ear. They will say that the ear is leaking, they notice it on the pillow. That should point you more towards chronic suppurative otitis media versus externa, although, you know, in medicine there is no absolute, so it's going to require you having a look into it a bit further to see which one you might think it may be. So this is the pathophysiology. I linked the article in the bottom if you're interested in reading up more formally, but essentially, as you can see, dysfunction, the bugs get involved, they continue to disrupt that dysfunction, and then you get inflammation, scarring, remodeling, and as you're going to see in the next slide, some rather dramatic pictures of what happens if we don't get on top of it early. So it's really an unhappy, eroded, destroyed middle ear. And it can even have the top slides actually superimposed fungal infections, which looks pretty dramatic. So how are you going to manage this? Well, the measures that we offer really in this, as again, is you've got to keep the ear dry. And dry mopping is what the EDL suggests. So essentially what you need to do is roll up ribbon gauze or some other gauze variant that you can be able to insert the ear safely, not an earbud. You roll it up into sort of a thin straw of sorts, and then you're going to put it inside the ear and then roll or wick until it is soiled, and you pull it out and you roll a brand new clean one, and you keep doing that until the gauze returns dry. That needs to be what they need to do rather judiciously to treat it. And you must consider perhaps again HIV, and the EDL says please don't send off the pus for MCNS. So that's really the treatment we offer, and that it can be quite difficult, and patients often struggle to get it right, but that it is a tricky thing to do. I actually tried in one of my consults to try it, and it's not as easy as I thought it was going to be. So who are you going to refer? A sick child, and whether you think this perhaps is now extended, so mastoiditis. If this discharge is not, you're not getting on top of it within a month, despite your best efforts, you'll need to refer them on. And if there's perforation in the attic of the tympanic membrane, or in terms of hearing loss, you're going to refer these children. And now I'm going to be handing over to my colleague who will be taking over for the nose and throat part of this presentation.
Good afternoon, everyone. I'll be continuing the presentation. So first up is allergic rhinitis, described in the EDL as an atopic disease presenting with symptoms of sneezing, nasal congestion, clear rhinorrhea, and nasal pruritus. Symptoms are what I'm sure we're all familiar with, that of a blocked stuffy nose and a watery clear nasal discharge. Patients may also be sneezing with associated pruritus and nasal passage irritation. It's important to exclude in the setting of suspected allergic rhinitis other causes of a runny nose, such as infections, overuse of decongestant drops, and side effects of chronic medications that the patients might be on. Allergic rhinitis is really a diagnosis of exclusion and should not be a first-line diagnosis because the treatment involves steroid use as well as antihistamine use, which are not benign drugs to be prescribing. So in terms of treatment, avoid allergens and irritants if they have been identified. For adults and children above the age of 6 years, a corticosteroid nasal spray is recommended by the EDL with 3-monthly review. Antihistamines are recommended only for short-term symptomatic management and not for children under the age of 2 years. And long-term use of antihistamines only after an adequate trial of nasal decongestants. Referral would be for those patients with severe symptoms or chronic persistent symptoms. Um, it's important to note that in our population, we might have HIV positive patients on protease inhibitors. So that would be leponivir, ritonavir. And sometimes these patients might require nasal steroids. However, our protease inhibitors inhibit the hepatic cytochromes and all those various isoenzymes, resulting in significant drug interactions, specifically with inhaled or intranasal corticosteroids that can result in adrenal insufficiency, iatrogenic Cushing's, hypertension, osteoporosis, and a decreased CD4 cell count. So the EDL recommends that any patient on a protease inhibitor should rather be referred to an HIV clinic or to an ENT clinic and not be managed at the local clinic level. This picture is just to serve as a reminder of the allergic facies, which we so often see in children with the presence of the Denny-Morgan lines underneath the eyes, the allergic shiner, the nasal crease from that allergic salute with the palm of the hand pushing up the nose, and the open mouth just to demonstrate mouth breathing if these children have permanently blocked noses. Next up is viral rhinitis, and as Troy alluded to earlier, in our current setting, we really need to be cognizant of COVID being a risk in all of our patients that we do see. So the EDL describes viral rhinitis as a self-limiting viral condition that may last up to 14 days and has multiple virological etiologies, such as the rhinovirus, RSV, influenza or parainfluenza virus, adenovirus, and obviously the coronavirus. Complications of viral rhinitis would be secondary bacterial infection in whatever form that takes. Pneumonia, otitis media, sinusitis, a postnasal drip could also complicate with the tonsillitis. So just be aware of the current NICD guidelines for PUI patients and then manage the symptoms as per these guidelines, as the EDL's treatment is also the same as the symptomatic management in the NICD for mild COVID-19. Next up is acute bacterial sinusitis, which is a bacterial infection of one or more of the paranasal sinuses that occurs most often after a viral nasal infection or as a complication of ongoing allergic rhinitis. It's generally a deterioration of a common cold after 5 to 7 days, and patients can complain of sensation of facial pressure or facial fullness. On examination, there might be periorbital edema, pain and tenderness over one or more of the sinuses, and a purulent nasal discharge, which is quite significant, especially if unilateral, nasal obstruction, fever, and tender cervical lymphadenopathy. EDL mentions that sinusitis is uncommon in children under the age of 5 years as the sinuses are not yet fully developed. Treatment again is antibiotics with an age-adjusted dose and analgesia. Referral would be fever lasting more than 48 hours, patients with poor response to treatment more than 5 days, localized edema over sinus, recurrent sinusitis, or again meningeal irritation, so that you'd be concerned about intracranial spread. Next up, we'll discuss tonsillitis and pharyngitis. Pharyngitis being a painful red throat, and then tonsillitis, enlarged or inflamed tonsils, generally the result of an infection that may be viral or bacterial. To note that we are particularly concerned with group ABT hemolytic strep and its link to rheumatic heart disease, Staph aureus, strep pneumo, and Haemophilus influenza. In unvaccinated patients, we need to also consider Corynebacterium. In our older sexually active patients, HIV, syphilis, gonorrhea, and chlamydia are also to be considered, and TB is again a consideration in recurrent tonsillitis. These patients would complain of a sore throat, they'll be systemically unwell. So general measures, a mouthwash, glycothiamol if we have it at the clinic, or homemade salt mixture, or warm tea with honey and lemon. The goal is purely to just soothe the throat. For breastfed infants, you can just encourage the mother to soothe the throat with breast milk and advise adequate hydration, especially in our younger kiddies who with the odynophagia or dysphagia might not be eating as well as they usually do. Furthermore, analgesia is recommended, and then antibiotics are not required for all patients presenting with a sore throat. If you are particularly concerned that this could be a strep throat and the patient is at risk of rheumatic fever, then antibiotics can be prescribed. Our patients that are at risk of rheumatic fever are in the age group of 3 to 21 years, and they have a sore throat plus one of the following, that being an exudate on the tonsils, no cough, and no runny nose. Antibiotics available to us are IM benzathine penicillin, oral amoxicillin, oral phenoxymethyl penicillin, or zithromycin orally if patients are allergic to penicillin. Referral is for any patient with suppurative complications such as a retropharyngeal or peritonsillar abscess, tonsillitis complicated by trismus, recurrent tonsillitis, and the patient is likely a candidate for tonsillectomy. If you suspect rheumatic fever or glomerulonephritis and heart murmurs not previously diagnosed. Paradise criteria for tonsillectomy is a useful criteria to use in patients that to identify patients that will benefit most from tonsillectomy, as this is not a benign procedure and is not for all patients with tonsillitis. The criteria is only to be used in patients between the age of 1 and 18 years in whom a tonsillectomy is seriously being considered, and is not for children with a host of other comorbidities that might qualify for a tonsillectomy outside of the criteria. So these images just demonstrate pharyngitis on the right, tonsillitis top left, and the Paradise criteria are mentioned there in the bottom left corner. Epistaxis is the last condition described in the EDL, and basically it's a bleeding nose that may be related to a localized or systemic disease such as trauma, hypertension, inherited or acquired bleeding diatheses. Management starts quite conservative, just by pinching the nostrils together for 10 minutes with the patient sitting and leaning forward. In most cases, this stops the bleeding, but it's important to note that with hypertension being the most common associated finding, cases of severe or refractory epistaxis, that blood pressure needs to be checked in these patients. If they are hypertensive and there are no other contraindications to a fluid bolus, that would be the treatment of choice. And if they are hypertensive, we can offer them a BIP-soaked ribbon gauze that can be packed into the affected nostril or nostrils, and then the patient can return the next day to have the BIP gauze removed, and then also to review any possible underlying cause that might be causing the epistaxis. Referral would obviously be recurrent epistaxis and failure to stop the bleeding at the clinic level. Next up are the 3 conditions that we felt are commonly seen at primary healthcare facilities but not covered in the EDL. First is dizziness, which the APC handbook gives a useful schema for determining which patients require urgent and non-urgent attention. Patients requiring urgent attention and warranting same-day referral are basically patients with new onset stroke or TIA symptoms, hypertensive patients, bradycardic patients or patients with an arrhythmia, hypoglycemia, associated chest pain, shortness of breath, history of a recent head injury, or new onset severe dizziness with nausea and vomiting, abnormal eye movements, or gait disturbances. In your non-emergent cases, obviously check the hemoglobin, the blood pressure, Try and inquire about the ear symptoms and other related symptoms, inquire about syncopal episodes, screen for alcohol and drug use, and review possible medications that might be the cause. This schema is just a memory aid to help with the differential diagnosis of dizziness, and just is intended to serve as a reminder that not all dizziness is vertigo or just orthostatic hypertension, especially in our elderly, and that we need to be cognizant that not all dizziness is related to ENT cases, but could have could be of multi-organ etiology. Next up is foreign body, be it in the ear or in the nose. And the most important indication for removal at the primary healthcare facility is whether or not you have a cooperative patient. If you have an adult or a teenager that's willing to sit still, you can attempt removal at the primary care facility. But basically, you need to ask yourself, can I manage the complications? i.e., if there's something small and round in a child's nose and they aspirate it, will I be able to manage that complication? If not, you should rather refer sooner than later. Also, if you are attempting to remove at primary care facility, it's recommended that you choose a maximum number of attempts that you will attempt removal, that it's agreed upon by yourself and the patient, and that you refer them after your 1 or 2 attempts. Finally, impacted cerumen. At local clinic level, I'm sure we've all heard of sweet oil, which serves to soften the cerumen in the ear to aid with removal. Although there are many different methods of removal at primary care level, for us, we have ear irrigation or syringing, basically filling a large syringe with warm water, asking the patient to hold a container under their ear to catch the water, to gently pull the ear backwards and upwards to straighten the ear canal, and then being careful not to inject the water against the tympanic membrane, but rather towards the superior or the roof of the ear canal to gently get out the cerumen and not cause further trauma. So that brings us to the end of our presentation. We hope that you feel more equipped in managing these common ENT conditions that we see in the clinic, and we would just like to re-emphasize that with COVID-19 and the current clinical setting, that universal precautions are always your top priority. Thank you very much. These are just our references that we used.
Alrighty, that was very nice and succinct. Do we have any questions or comments from the audience? Yes, Cora, I see you raised your hand.
Hi, Dr. Murphy. Thank you, Troy and Ingrid, for a great presentation. I would just like to ask, I've had a case in the clinic where I had a lady coming in with ear pain and otorrhea. And on the examination with the otoscope in the ear, I saw that she had a small tympanic membrane perforation. I couldn't find any proper guidelines on what we do at a primary health level or referral on EM guidance. I was just wondering if you could maybe shed some light on how we can go about possible eardrum perforations on a primary healthcare level.
Okay, Cora, that's a good question. So you mentioned that there was a discharge associated with the perforation. Was it a separative discharge?
Yes,
or...
yeah.
Alrighty. And can you describe what sort of component or what aspect of the tympanic membrane was perforated? Can you recall? If you can recall from the slides of Troy's presentation, just the anatomy of the tympanic membrane, you have the sort of a larger window, and then you have the stapes and the incus and the bone, and that produce the light reflex, and then superior to that, you have the sort of the attic of the tympanic membrane.
Yes, so it involved that attic, yeah.
Okay. So tympanic membrane rupture is quite common, and we do see it a lot in children, and generally it does have good opportunity to sort of re-epithelialize and form itself in 1 to 2 weeks. The general advice is that we say to avoid getting water in the ear or any sort of foreign body or fluid. And then particularly attic perforations, so the small top at the part of the bone are less likely to heal, so they should be referred. But in the case of a simple uncomplicated perforation, you can just give them general advice. If you do see any form of a discharge or concern of infection, you should provide otic drops in the form of a suspension as opposed to a solution, just for reducing the damage to the inner ear, and then dry mopping and wicking. So in this lady, if you were certain that there was a attic perforation, I would provide dry mops and then a otic suspension, and then refer her to ENT. However, if it was sort of the greater tympanic membrane that was involved, then you could follow her up as an outpatient. I see Michelle has her hand up as well. I'm sure she can give us some insight into this.
Hi, Shane. Can you hear me?
Yes.
Okay, because often this thing doesn't work very well. It wasn't into what you were saying. Sorry, it was just another small point I wanted to raise. One of my pet things.
Okay, sure. Just before that, then, Cora, did that answer your question?
Yes, thank you so much, Dr. Murphy. Thank you.
Okay, sure. Apologies, Michelle. Yes.
My comment is just around the use of the short-acting nasal decongestants, Iliaden. You know me on this one. People tend to overuse them, especially in allergic conditions. So I think you probably made it, mentioned it quite quickly in your allergic rhinitis chat. But yeah, just don't use them for more than 3 days. Don't use them for chronic conditions. Shane can add to this. And then just also in the technique, did they talk much about the technique of using steroid nasal sprays?
We did not speak to the specific technique.
Okay, I don't know if you want to tell them, or if the person who did the presentation read up on that much. But that's
Sure.
one of the important points, because there's no point using the sprays incorrectly, and also nasal irrigation before you use the sprays. Otherwise, and it takes a bit of time to show the patients. So I think there are a few gaps in the way we manage patients, because we kind of just send them off to the pharmacy and don't give them that information.
Definitely. Troy, do you have any comment on what Michelle is referring to in terms of the technique for nasal steroid administration?
So, I mean, from the reading that I did, I didn't know if there's anything specific to corticosteroid intranasal spray, but that the patient should insert it into the affected nostril. They should aim towards their eye. They shouldn't be aiming towards the center of the head, and they mustn't excessively sniff, is all that I really came across. I don't know if there's any other specific that we need to tell them about.
So just to rehash what Ms. Michelle said about the Iliaden, is that we know that does sort of reduce duration of symptoms for acute viral rhinosinusitis, but we get that rhinitis medicamentosa, and so that's why we limit the duration to 3 days. And then Michelle spoke to the nasal irrigation, and so what that does is sort of just clear any secretions and sort of lay the path for the steroids to take effect. And classically, the technique, Troy, is not towards the eye. If I want to instill the spray into my left nostril, I should use my right hand, and so as to direct it towards the lateral aspect of my eye, or even to the towards the tragus of the same side. So there's that crossed effect that aims it more laterally, and then similar for the right nostril with the left hand. Is that clear? Does that make sense?
Yeah, crystal.
They can always YouTube it as well, Shane, but it's good to just see.
Yes, definitely. And interestingly, the Barra POPD says that the most common cause of unresponsive or untreated asthma in our community is sort of a misdiagnosis of allergic rhinosinusitis, and it's unmanaged. And so you have this child that has these massive pectoral muscles and these lines from this chronic asthma state, and he's not responding to treatment, but it's because we've missed the allergic rhinosinusitis that gives a recurrent drip. And so that's also another important consideration.
Shane, can I just add to your comment now?
Yes, sure, Dr. Petrova.
That children, you can recognize them by their facial expression. You've heard about that allergic salute. Does anybody know what's that? Can you hear me?
Yes, we can hear you, Dr. Petkova. I think
I'm asking the
Ingrid,
interns. I'm asking the interns if they know what is the allergic salute.
yes, Kerry, I see you have your hand up. Would you like to answer the question?
Oh, no, it was to do with another question. But yes, Dr. Petrova, we do know what the allergic salute is. As the presenter explained, it's from continuous rubbing of the nose upwards, and then you get a crease in the nose.
Only. Is it only a crease or something else?
That's as far as I know.
Yeah. Okay. So I just want to give you some practical tips. If you see a patient with very clean ear inside, and the patient is complaining of a sore ear, which means that this patient is cleaning too much the ears and doesn't even have a wax inside. So the external otitis is very common for such patients. So please advise your patients not to clean so many times. And some people do it after each bath, which is not necessary because they practically clean the wax, which is a protective in the external canal and doesn't allow for any infection to penetrate deeper inside. That's one thing. Second thing is, which I wanted to say, is the mopping. The mopping of the chronic condition, of chronic ear condition, is to be, you need to teach the patients how to do it themselves at home. Just keep in your minds that there is no antibiotic which is going to help in treating that chronic otitis. You need to teach the patients how to do the mopping. On a match, you put the cotton, roll the cotton, but the top of the cotton, it mustn't be shaped as the earbud is shaped, which means it mustn't be smooth on the top. It must just protrude a little bit of that cotton which you rolled on the match. And they need to do it on one session, maybe 6 to 8 times, and maybe 3 to 4 times a day. So each session must be 7, 8, 9, 10 times to roll that cotton on the match. I know it's not easy, but some patients are keen to get rid of that terrible leak of their ears, and they do it, and they really dry up the ear canal there, which is full of pus. That's another tip I wanted to tell you. The other thing is, during the dry season in South Africa, you can find even young children with the bleeding nose. This is not because the blood pressure is elevated or they've got some problems. and it doesn't mean you don't need to investigate what is the cause, but most of the time is the dry weather which cracks the membranes inside of the nose and they start bleeding. So you can advise the patients to just smear a little bit of Vaseline inside in the nose, so to prevent that cracking and bleeding of the nose. Thank you.
Thanks, Dr. Petkova. Kerry, if you would like to ask your question now.
Thanks. I just wanted to ask, when they have the complication of post-nasal drip, is there anything we can do or advise the patients to do for the post-nasal drips?
So I think, as we were saying, sort of the mainstay of the therapy post-nasal drip is as consequent of allergic rhinosinusitis. And so the mainstay of therapies would be non-pharmacological in terms of advice to sort of dust or fomites or sort of animals around the house and the sheets that they use. So reducing the allergic load per se. And then the pharmacological and just sort of other measures that we have discussed in terms of the saline irrigation through the pot, and then the regular use of nasal steroids. And then as we follow the stepwise progression then to long-term daily non-sedating antihistamines. So yeah, and another key aspect is that the chronic allergic rhinosinusitis with postnasal drip, they often suffer from academic underperformance and sleep problems, all due to the postnasal drip and sort of the sleep apnea that could follow from that, and the daytime somnolence. So it is quite an underappreciated question that we can manage. Kerry, does that answer your question? Yes, Kerry? I think you're still muted. Alrighty, do we have any other questions or comments?
I just want to make a comment, Shane.
Yes, Dr. Petkova.
People don't realize that also the use of aircon in their cars also can trigger that postnasal drip, because you don't even feel like the aircon is blowing in your face, and then in the end of the day you feel like congested in your nose. So don't forget to explore that with your patients. And I don't know what advice you can give them, but during the summer time to drive without an aircon, it's just almost impossible. But that is another trigger of a postnasal drip. And also the aircon is not very clean. We know that it has the cleaning system, but also contains a lot of allergens. So that is another trigger for postnasal drip and the allergic rhinitis also.
Yes, definitely a consideration. Alrighty, if there are no further questions or comments, do we have a second presentation for the afternoon?
Hi, Dr. Murphy. Yes, we do. Myself and my colleague Anne van Staden are presenting common dermatological conditions in primary health care.
Nice. Dermatological considerations. That's always a tough and a big one. I'll make you co-host, and you can feel free to
Thank
start.
you.
Sure.